Good morning to you all. Today's topic is on periodontal treatment of female patients. The learning outcomes are: first one, recognize the periodontal changes with respect to different stages in female patient, summarize the periodontal manifestations and their management, explain the drawbacks in use of oral contraceptives and its management in periodontal disease, and the last one, explain the gingival changes among female patients in clinical practice. The contents include introduction, puberty gingivitis, menstrual gingivitis, pregnancy gingivitis, menopausal gingival stomatitis, use of oral contraceptives, and then finally conclusion. Introduction. Throughout a woman's life, hormonal influences affect the therapeutic decision making in periodontics. So these hormonal changes they are reflected in their periodontal tissues throughout their life, so which increases the risk of periodontal diseases. This is why because the sex steroids exert profound biological effects on immune function and bone metabolism. Therefore, it is imperative that the clinician recognize, customize, and appropriately alter periodontal therapy according to the individual woman's needs based on the stage of her life cycle. So let's start with the puberty gingivitis. So first we will discuss with the etiology. As we said before, that is, it is mainly due to the increased level of hormones like estrogen and progesterone. When there is increased level of these hormones, which increases the blood flow to gingiva and which raises the sensitivity and reaction to irritants. And there will be increased amount of gram-negative anaerobes, especially Prevotella intermedia. So this will be using this ovarian hormone as a substitute for vitamin K growth factor. As this ovarian hormones and the vitamin K, they share the similar structure. So this Prevotella intermedia will be using or might be using this ovarian hormones as a substitute for the vitamin K growth factor. As the ovarian hormones level is increased, so whereas the action and the production will be more in of the Prevotella intermedia, and also other than that there will be increase in Prevotella nigrescens, Capnocytophaga, species motile rods, and spirochetes. So let's move on to the clinical features. As you said, that is, it is seen in the puberty stage. So the average age is 11 to 14 years of age, and there will be exaggerated response to the local factors, and which appears as inflamed tissues that become erythematous, lobulated, retractable, and which feels tender and bleed easily. And histologically, these inflammatory hyperplasia can be seen. And when there is inflammatory hyperplasia, this can be seen as gingival enlargement also. And also there will be increased bleeding tendency that is mainly due to this increased like capnocytophaga species. Then comes the management. Preventive care, including vigorous program of oral hygiene maintenance, is vital. That is, for mild gingivitis, scaling and root planing with frequent oral hygiene reinforcement can be done. And in severe cases, this might require microbial culturing, antimicrobial mouthwashes, and local drug delivery or antibiotic therapy. Sometimes this gingival enlargement can be seen, so this can be treated by scaling and curettage and removing all the irritants and controlling plaque. And if it's further, if the enlargement persists, then you can go for the gingivectomy also. That is, surgical removal may be required in very severe cases. Next, we are going to discuss menses or menstruation and the gingival changes associated with this menstruation and what is responsible for this gingival changes. That is, this ovarian cycle is controlled by the anterior pituitary gland, as the picture indicates. So, uh, so this is anterior pituitary gland. So this will be like this will be controlling this ovarian cycle. That is, mainly it produces the gonadotropin, follicle stimulating hormone, and the luteinizing hormone, and produced by the anterior pituitary gland. So under the influence of this luteinizing hormone and the follicle stimulating hormone, this will be acting on the ovary to produce the hormones like estrogen and progesterone. So as we said before, these are the main steroid hormones that are produced by the ovaries during the menstrual cycle. So then coming to the etiology of gingival changes. So this can be easily be explained by the menstrual cycle phases. So this menstrual cycle has got two phases. That is, first one, that is the follicular phase. So here the levels of follicular stimulating hormone will be more, and as well as the estradiol, the major form of estrogen, is also synthesized. So it will be like increased level in the follicular phase. Where it comes to the luteal phase, there will be more amount of estrogen as well as the progesterone. So this synthesizes both estradiol and progesterone. So this estrogen peaks at zero point 0.2 nanogram per ml, and progesterone reaches as 10 nanogram per ml. So, as we said before, during this menstrual cycle, this estrogen and progesterone increase inflammation in gingival tissues, and which exacerbate the response to local irritants. So, this inflammation seems to be aggravated by an imbalance or increase in the sex hormones. So, this menstrual cycle irregularity is a risk indicator for a periodontal disease before menopause. So next, coming to the mechanism behind this menstrual gingivitis. So as we said before, when there is increased amount of progesterone and estrogen, there are medius effects, that is under progesterone, which increases the permeability of vasculature and altering the rate and pattern of collagen production in gingiva, and also it alters neutrophil chemotaxis and stimulation of prostaglandin production. Whereas estrogen, which leads to the increased cell proliferation in blood vessels, and also it decreases the keratinization. So other than this, there are several factors which increase the gingival inflammation. They are fluctuation of TNF alpha during menstrual cycle, and also elevated prostaglandin synthesis, and angiogenetic factors and endothelial growth factors, and also the modulation of receptors by these hormones. Then coming to the clinical manifestations, gingival bleeding, redness or swelling of gingiva, sores on the inside of lip and cheek, burning sensation, and increase of gingival exudate can be seen. And this can be seen during ovulation or pre-menstruation, that is a stage occurs right before a woman's period and clears up once her period is started. There is a like premenstrual syndrome. There is a stage where that is before the stage before the occurrence of menstruation. So here the patients will be more sensitive and less tolerant of all the procedures, and have a heightened gag reflex, and may have an exaggerated response to pain. Coming to the management of menstrual gingivitis, oral hygiene maintenance is essential, including at home oral hygiene and also the regular professional dental care. And patient's physician should be consulted, and hormonal levels should be monitored. That is a basic procedure. So, increase if there is any increased gingival bleeding and tenderness associated with this menstrual cycle, this will require close periodontal monitoring. So for that, periodontal maintenance should be adjusted to the individual's patient needs. So if it is problematic, at least 3 to 4 month recall interval should be recommended. And also an antimicrobial oral rinse before cyclic inflammation may be indicated. And in case of history of excess postoperative hemorrhage or menstrual flow, scheduling surgical visits after cyclic inflammation is prudent. And also obviously there will be anemia that will be common due to the increased blood loss, and appropriate consultation with the physician and recent lab test should be maintained. So next, coming to the next stage, that is pregnancy. The link between the pregnancy and periodontal inflammation has been known for many years. In 1877, Pinard recorded the first case of pregnancy gingivitis. Pregnancy gingivitis is extremely common, occurring in 30% to 100% of the pregnant women. It is characterized by erythema, edema, hyperplasia, and increased bleeding. Cases range from mild to severe inflammation, which can progress to severe hyperplasia, pain, and also bleeding. So then coming to the pregnancy gingivitis and its main causes, as we said, that is during pregnancy the sex hormones levels rise dramatically. That is, it's much higher than the that under menstruation. So the progesterone reaches levels of 100 nanogram per ml, that is, which is 10 times the peak luteal phases of menses, and estradiol in the plasma may reach level 30 times higher than during the menstrual cycle. So as we said before, as these hormones levels are increasing, which will accentuate the gingiva response to plaque. And also this is mostly seen in the third trimester of pregnancy. So whereas this estrogen secretion increases, and whereas this progesterone secretion remains constant or decreases slightly. So during this pregnancy, there will be like the increased amount of estrogen and progesterone level. That is mainly this. They have found that this placenta begins to produce the estrogens and progesterone. So that is the main reason for this much higher increase in the sex hormones. Clinical manifestations in pregnancy gingivitis. So about 30% to 100% of all pregnancy women this can be seen, and also usually starts in second or third month of the pregnancy, and then it slowly worsens by the 8th month. And this accentuates the gingiva response, which results in pronounced inflammation to plaque. And gingiva is the most common site involved, that is approximately 70% of the cases, followed by tongue, lips, buccal mucosa, and palate. And this can be seen as erythematous, hyperplasia, ease of bleeding and tenderness of gingiva, pocket formation, and also transient mobility. Gingival changes are usually painless unless complicated by an acute infection. An increase in the attachment loss can represent the active periodontal infection that could be accelerated by the pregnancy. The most common site, that is anterior region of the mouth and interproximal sides, tend to be involved. So gingivitis that is seen in the anterior region mainly due to the mouth breathing, that can be called as pregnancy rhinitis. So microscopically, that is, you can see that epithelium hyperplastic with a reduced keratinization, and also this accentuated retipex you can see, and also this marked inflammatory cell infiltration occurs with edema and degeneration of the gingival epithelium. Then coming to the gingival enlargements in pregnancy, it can be either marginal gingival enlargement or tumor-like enlargement, is called as pregnancy epulis or pregnancy granuloma. And this marginal gingival enlargement that is seen as generalized, more prominent in the interproximal region, and it appears as bright red or magenta. Bleeding occurs spontaneously or on slight provocation. Whereas this pregnancy granuloma that is appears as discrete mushroom-like flattened spherical mass that protrudes from the gingival margin, and it's more seen interproximal space, and it can be occurred either as sessile or pedungulated, and which can be bleed easily. So which ranges in color from purplish red or dusky red or magenta to deep blue color, depending on the vascularity of the lesion and the degree of venous. It often exhibits numerous deep red pinpoint markings. So the main reason behind this gingival enlargement, that is mainly increase in levels of progesterone and estrogen. So end of third trimester that reaches the levels like 10 and 30 times the levels during the menstrual cycle. So which induces changes in the vascular permeability, and which leads to finally the gingival edema. And also along with that, there will be an increased inflammatory response to dental plaque, and also there will be increase in prevotella intermedia. So these are the main reasons behind the gingival enlargements in pregnancy. So coming to the causes of gingival responses to elevated estrogen and progesterone levels during pregnancy. So the main etiological or the local factor, predisposing factor, that could be the subgingival plaque composition, and there will be increase in anaerobic or aerobic ratio and higher concentrations of the prevortal intermedia, as we said before, and also higher concentrations of Bacteroides melanogenicus and Porphyra monogingivalis. Other than that, this maternal immunoresponse could be get affected. That is mainly the depression of cell-mediated immunity, decreased neutrophil chemotaxis, and depression of antibody and T cell responses, and also decrease in ratio of peripheral T cells to T suppressor cells, and also cytotoxicity directed against macrophages, and decrease in the CD3 plus and CD4 and CD19, and also the stimulation of prostaglandin production. So some of these you can just remember for the exam purpose. And also more than that, the sex hormone concentrations, they are also like increased, and they could affect like estrogen, which causes increases cellular proliferation in blood vessels, decreases keratinization while increasing epithelial glycogen, Specific receptors are found in gingival tissues, and also progesterone that is increases vascular dilation and thus increases permeability, increased proliferation of newly formed capillaries, and alters the rate and pattern of collagen production, increased metabolic breakdown of folate. Specific receptors are also found in gingival tissues, decreases plasminogen activator inhibitor type 2, and this both these hormones they act together could affect ground substance of connective tissue by increasing fluidity concentrations, increase in saliva and fluid with increased concentrations in serum. So next condition is that periodontal disease and preterm low birth weight infants. So often Bucker et al. Has found that this untreated periodontal disease in pregnant women could be a significant risk factor for the preterm labor. That is, if the delivery is before 37 weeks of gestation, or if the low birth weight, that is, if the baby is of just less than 2,500 grams, then that is called as this low birth weight infants. So this could be mainly the reasons behind it is that translocation of periodontal pathogens, effects of endotoxins, or effect of inflammatory mediators. So then there will be like inflammation. So this inflammation which leads to placental vascular alterations or the low perfusion of nutrients can be one of the reason. And also this inflammation leads to the complement activation pathway, whereas this get activated due to this ILM8, interleukin 8, and TNF alpha, so which leads to the production of prostanoids. So prostanoids either acts by direct on this contraction on uterines, which leads to the preterm birth, and also this could produce the proteases, and which finally leads to the premature rupture of the membrane and finally the preterm birth. So then comes the mechanism by which infection may induce preterm labor. So this clinical pictures that shows clearly shows the mechanism by which the infection can induce the preterm labor. Not only the bacteria alone, and also the bacteria products, and also the inflammatory like mediators like pro-inflammatory cytokines also lead to like hematogen dissemination to various aspects, and also which reaches the placenta, which could lead to this placental inflammation, and also which again leads to the inflammatory mediators, and which could lead to bacterial invasions of the membranes and placenta, and thereby increased amount of prostaglandins, and which leads to the membrane rupture and finally to the preterm birth. So this bacterial infection and its products in amnion, which leads to the inflammatory response with cytokine production in amnion, and this increased amniotic prostaglandin production, which leads to preterm labor. And also these authors have found out that fusobacterium nucleatum has been linked to this preterm low birth weight infants. Then next we could explain the two other conditions related to pregnancy, that is preeclampsia and gestational diabetes. This preeclampsia that is characterized by hypertension and proteinuria after 20 weeks of gestation, and this periodontal disease they have found that this could increase the risk of preeclampsia by 2 to 2.5 folds. And also this gestational diabetes, that is a condition in which a woman without diabetes develops the high blood sugar levels during her pregnancy. So this inflammation caused by the periodontal disease might interfere with the proper insulin function. So this could be the reason for the high blood sugar levels during pregnancy. So, coming to the management, that is establishing a healthy oral environment and maintaining optimal oral hygiene levels. That is the main important thing, that or the first line of treatment for this pregnancy related gingival changes. And complete medical history should be recorded, and preventive periodontal program, that is nutritional counseling as well as rigorous plaque control measures in the office and at home is mandatory. And also scaling polishing root cleaning may be performed when necessary during pregnancy. And avoid this elective dental care, that is the first stage, that is during the organogenesis, and the last half of third trimester, that is due to the hazard of premature delivery excess because the uterus is very sensitive to the external stimuli. And also this prolonged chair time should be avoided, that is to avoid the supine hypertension syndrome, that is due to the more pressure on the vena cava, as the diagram shows. That is, if there is prolonged chair time, this could affect this vena cava, can be like pressure on the vena cava, so this leads to the supine hypertension syndrome. So this can be reversed by turning the patient on left side, thereby removing the pressure on vena cava. Or a preventive 6-inch soft bed should be placed on patient's right side when she is inclined for treatment. Second trimester is the safest period for providing routine dental care, and also emphasis at this time is on controlling active disease and eliminating potential problems that could arise in late pregnancy. So then coming to the radiographs and medications during pregnancy, whether it can be taken or how it can be taken. So that is mainly depends upon the dental radiographs should be avoided in the first trimester. Lead apron should be used, and X-ray film should be taken selectively during pregnancy and only when necessary and appropriate to aid in diagnosis and management. And in most cases, you can go for bite wing, panoramic, or selected periapical films are indicated. And medications, ideally, no drug should be administered in pregnancy, especially first trimester. And antibiotics are often needed in periodontal therapy. The effect of a particular medication on the fetus depends on the type of antimicrobial dosage, trimester, and duration of course of therapy. Then coming to the drug risk classification, FDA has put forward different categories like A, B, C, D, and X. So A, which shows no risk to the fetus, and B with like no animal studies have shown that no risk to the fetus, no control studies have been conducted in humans. Whereas C, that is no control studies have been conducted in animals or humans. So and D, that is shows that may outweigh the evidence of risk to the humans exist. And also X, that is like totally demonstrated like fetal abnormalities. So out of these categories, this A and B is more safest than the other categories. And also under antibiotic administration, you can see this penicillin, erythromycin, clindamycin comes under the B category. So this can be taken during pregnancy with some of the risks like diarrhea, jaundice, and all. And also this tetracycline, that is should be avoided. So there is evidence of depression, the bone growth, enamel hypoplasia, and gray brown tooth discoloration. And also this you can avoid the ciprofloxacin also, and gentamicin, and whereas this clarithromycin is totally should be avoided. Okay, so this there are shown that this could cause adverse effects on pregnancy outcome and embryo or fetal development. Then coming to the local anesthetic and analgesic administration, you can see that local anesthetics like lidocaine, mepivacaine, prilocaine, and all. So out of this, lidocaine and prilocaine and etidocaine, atricaine are more safe as compared to this mepivacaine, like long-standing like anesthetic agents. And under analgesics, you can see this aspirin is totally avoided mainly during this third trimester, and safest one is that acetaminophen and this hydrocodone and oxycodone. Okay, and then coming to the sedative penodal drug administration during pregnancy, so this should be totally avoided during pregnancy, that we can see. And this local anesthetic and analgesic administered during breastfeeding, you can see that all this lidocaine, mepivacaine, everything is safe, whereas this aspirin should be avoided. And also this hydrocodone, like which doesn't contain any data, so this can also be avoided during breastfeeding. So then coming to the treatment algorithm for pregnant patient, so this can be like given as women of childbearing age or the pregnant patients. So what they can go under oral hygiene, periodontal exam or charting, review effects of female hormones in the periodontium. So they can go under routine checkup for the possible effects of periodontal inflammation on the unborn fetus. Periodontal maintenance can be done, so we can categorize them under either periodontal stable pregnant patient or pregnant patient with inflammation. For the periodontal stable pregnant patient, what we can go for the safest, that is to treat during second trimester. If there is any mild inflammation, and that is with scaling and the routine root planing also, and all periodontal maintenance can be done, but avoid category C and D medications. Whereas a pregnant patient with inflammation can consult with the gynecologist first, or the consultant doctors, and you can do go for the debridement like preferred in the second trimester. Okay, but if moderate to severe, then this can be done regardless of the stage of pregnancy, but it's better to postpone. Like if it is not that much severe or affecting this preterm labor and all, then you can postpone like after delivery. Otherwise, you can do the treatment like regardless of the stage of pregnancy, and avoid category C and D medications. So then coming to the menopausal gingival stomatitis, that is a gingival changes associated with the menopause. So this is a condition where there is cessation of menstruation, and which occurs during the age range between 45 to 55 years of age, and this is associated with the symptoms of estrogen deficiency actually. So during menopause, what happens is estrogen levels fall, while this follicular stimulating hormone and luteinizing hormone levels got a rise, like it is greater than 30, and this fluctuation of these hormones is mainly responsible for the inflammatory changes in gingival hypertrophy or atrophy. So these estrogen affects cell proliferation, differentiation, and keratinization of gingival epithelium. So these are some of the clinical features you can see, that is dry and shiny mucosa, thinning of oral mucosa, and this burning mouth can be seen, and also sometimes associated with the pain also, and gingival recession, and also this dryness, that is decreased salivary production, that is xerostomia or this altered taste, and also this alveolar bone loss and red resorption. Then coming to this this two stages like osteopenia and osteoporosis, that is associated with the menopause. That is, osteopenia is a reduction in bone mass caused by an imbalance between bone resorption and formation, which favors the resorption and resulting in demineralization. So, osteoporosis is a disease characterized by low bone mass and fragility and a consequent increase in fracture risk. So, this is mainly due to the less mandibular and maxillary bone mineral density, and which ultimately leads to the tooth loss due to the bone loss, and this alveolar ridge atrophy, and also this clinical periodontal attachment loss. This increased alveolar bone mass with associated improved alveolar crustal height, reduced clinical attachment loss, or reduced periodontal inflammation has been reported with patients on hormone replacement therapy. Management medical history should be reviewed. If gingival and mucosal thinning occurs, then they can go for the soft tissue augmentation. And brushing with an extra soft toothbrush may prevent the scrubbing of this like atrophic gingiva. So it's better to go for the extra soft brush compared to this medium or hard, and identifies us with minimal abrasives, and rinses with low alcohol concentration should be used. Root surfaces should be debrided gently with minimal soft tissue trauma, and close monitoring of the patient's periodontal stability, and should perform titrated periodontal maintenance. Inform the patient about the potential risk of this hormone depletion on oral mucosa, and advise to consult the treating physician. In patients receiving hormone replacement therapy, oral symptoms and tooth loss may be significantly reduced. So, if the patient is susceptible to osteoporosis, that is better, this dentist should consult this patient physician regarding the replacement therapy or vitamin D supplementation. So, they have put forward the National Institutes of Health recommends that 1000 milligram of calcium per day for premenopausal, and whereas 1500 milligram of calcium per day for postmenopausal women. So this is some of the guidelines for the like optimal calcium intake. You can see this premenopausal women for the age 25 to 50, 1000 milligram per day, whereas for the postmenopausal women that is 1000 milligram per day, and postmenopausal women no estrogen therapy, that is 1500 milligram per day, and for the men it can be 1000 milligram per day, and for the both like greater than 65, 1500 milligram per day. Then coming to the use of oral contraceptives. So that women may have responses to oral contraceptives similar to those seen in pregnant patients. So there will be increased with pregnant patients. It is mainly due to the increase in hormone levels. So whereas this oral contraceptives use that mimics the hormone levels of pregnancy, that is increased estrogen and progesterone. So this oral contraceptive use prevents the luteinizing hormone surge and at about less 11.5 to 12 days after menstruation, which prevents the ovulation. So this oral contraceptive associated gingival inflammation can be chronic also versus the acute inflammation of pregnancies. That is a major difference. That is, this could may become chronic in the easily because of the extended periods that women are exposed to elevated levels of estrogen and progesterone, not for a limited period. So for the extended periods, if they are exposed to this inflammatory mediators, that could be chronic. So, what are the clinical features you can see during for the patients using this oral contraceptives? Some of the features you can see: exaggerated response to local factors, as we said before, and inflammation. It could be mild edema and erythema, ranging to the severe inflammation, and also hemorrhagic or hypoplastic gingival tissues, and also and or of more exudate, and this increased response that is to the local factors that can be due to altered microvasculature, and also increased gingival permeability, and also due to increased prostaglandin synthesis. And also you can see that there is increased bacterioid species due to this female sex hormone substituting for naphthoquinone, that is mainly required of certain bacterioid species. You can see this will be mimicking the same feature as that of this naphthoquinone. So this will be replacing niptophenone with the female sex hormones, and there will be changes in salivary composition, and also in some conditions you can see localized osteitis. There is more in case of there is extraction of mandibular third molars, there will be increase in twofold or threefold increase in localized osteitis, and also the salivary composition could be changed, as we said before, that is decreased concentration of protein, salicylic acid, or some of the proteins could be changed in the salivary composition. And coming to the gingival melanosis can be seen in some cases. Okay, then comes to the management. You can see that inform about the oral and periodontal side effects of this oral contraceptives usage, and also and the need for meticulous home care and compliance with periodontal maintenance, and establish an oral hygiene program and elimination of the local predisposing factors. This could be the main risk factor for the gingival inflammation. And periodontal surgery may be indicated if resolution after initial therapy is not adequate. And it may be advisable to perform extraction of teeth, especially of third molars, on non-estrogenic days. That is days 23 to 28 days of the oral contraceptive cycle, to reduce the risk of a post-operative localized osteitis. Then coming to the conclusion, so we have covered all the stages of women, female, like different cycles, hormone cycles, and also their associated gingival changes. And coming to the conclusion that the cyclic nature of all these female sex hormones often is reflected in gingival tissues as initial signs and symptoms. So medical histories and dialogues should include thoughtful investigation of the individual's patient's problems and needs, and counseling should reflect hormonal stability and medications associated with regulation. Patients should be educated regarding the profound effects the sex hormones may play on periodontal and oral tissues, as well as the consistent need for home and office removal of local irritants. Thank you.